Good afternoon, everyone, and welcome to the Translation Manchester monthly seminar series. My name is Alessandro. Some of you might know me. I'm Translational Research Manager at the University, managing Translation Manchester. As you know, this series has been designed to feature the partners of the Translation Manchester Research Network. So this network includes over 50 facilities and institutions across the university and all its partner organizations, which are all aimed and focused on supporting translational research and researchers. You can find details on all of our partners on the booklet, which is downloadable from our website, and I think the link will be shared in the chat very shortly. Thank you, Jim, for facilitating that. And the idea is that each month, a couple of members of the network will come to this event and present and explain how and when in the translational journey they can provide support to you as academics or support staff. All the events are recorded and can be watched later on our YouTube channel. A link of that will be also put in the chat very shortly. So without further ado, I'd like to introduce our first speaker from today, Paul Hanmer. Paul has a long-standing career in innovation with experience both in industry and NHS. Currently works at Health Innovation Manchester, leading on the Innovation Nexus program. So this is the portal that brings your innovation into the NHS. And today, Paul is going to tell us a little bit more about this process. And Paul, thank you so much for coming, and the floor is all yours.
Okay, let me just get this one up. Are you okay, Alessandro? Can you see that?
That is perfect. Thank you.
Brilliant.
So much.
Okay, so thanks very much. Good afternoon, everybody. Thanks for inviting me to present today. As Alessandro said, I'm program manager for the Innovation Nexus service, and we kind of help innovations to access the NHS, and we're interested in spread and adoption. So what I thought I'd do today is distill some of the learnings from that process to give you some tips on how to translate a value proposition into an accepted product. Touch on a couple of case studies, and then at the end I'll talk about some of the support that's available. Oh, what's happened here? First step. Let's go with this. There you go. So where to start? So translating technology into usable product, it's a bit like translating a piece of text into a different language or moving something from one location to another. And it's not something that typically a scientist is naturally going to be good at. I mean, why should they? And it always seems a little bit unfair to rate a scientist such as Faraday higher than a scientist such as Einstein, just because Einstein didn't invent anything. Or so I thought, but as I was preparing for this talk, I actually I misrepresented Einstein. So he did have an invention as well as working in the patent office. But what I think I'd like to do is just give you a bit of insight into things to consider and a kind of framework you can use based on our experience on dealing with innovations to try and translate your innovation into something usable in the system. A useful way to look at this is to get what you want, which in other words is the adoption of a new product or service. You need to provide a coherent argument, and that's based really on three pillars. The need or the problem that you're trying to solve, the value that your solution brings to the system, and also the evidence that you plan to gather or you can present now. As you can see from the shaky pillar at the end, it's usually the evidence that is the weakest link. And ironically, I don't have enough time today to go into more detail on that, but it is something that I could come back at a future seminar to give you a little bit more information about the kind of evidence and how to gather it and help with that. But the other thing to remember is that there's often a lot of solutions to solve the problem or meet the need. So the value is really what adoptees will use to choose between those potential solutions. So it's important that you express the value in the right terms and persuasively. So we've been in lockdown for quite a while, so we've probably all started to hear voices, but the voices that I'm going to talk about are twofold. One is the voice of the customer, and the other is the voice of the business. So who is the customer in healthcare? So it's really got healthcare's got quite a relatively complex hierarchy of people who are involved in the buying decision, which I've tried to illustrate on this table. Obviously, because we practice medicine based on informed consent, the patient ultimately can accept or refuse treatment. But they're heavily informed by charities and healthcare professionals, obviously. Themselves are advised by health technology assessment organisations, and you might have heard of NICE, National Institute of Clinical and Healthcare Excellence. However, ultimately, procurement and finance have the job of providing best value and balancing the budget for a hospital, for example. So it's important really to have dialogue with all the stakeholders. They're all looking at, they all have an influence on the buying decision, and they're all looking for different elements of your value proposition. So the other important voice is the voice of the business. And you can think of this as, it's not only what you're doing, but how you're doing it. So institutions are trying to achieve their objectives in the most efficient way in line with government policies and advice. And these are actually some drivers that a transformation team in Manchester Foundation Trust have shared with us of what they're looking for in business cases and adoption of technology. So philosophers have wrestled with how to decide whether actions are right or wrong for a long time. And one attempt is a theory called Utilitarianism, which was developed by, amongst others, Jeremy Bentham. And this tries to calculate for a particular action the quantity of happiness that it produces. So you can compare different actions and choose the one that produces the most happiness for the most people. And Jeremy Bentham was so committed to this and thought you should make yourself useful both in life and death, that this is a picture of his auto icon, which is his preserved body that he donated to medical science. And for some reason, it's now on public display at University College London in the Student Union Department. So hopefully they are using him to the best value. But there's a similar problem for organisations delivering healthcare. Which products and treatments will lead to the greatest good for the greatest number of people? And how can you compare the benefit of, say, a hearing aid versus the benefit of a hip replacement, for example? So one measure, which is like a universal currency that allows you to compare the benefit of radically different treatments, is the quality adjusted life year, or QALY. So one QALY is equal to 1 year of perfect health. Now you can measure someone's health status using quite a general questionnaire called the EQ5D, 5D because it's got 5 dimensions. You can Google that, that's freely available. It's important that you measure QALYs over a reasonable time frame related to the disease condition in question. Otherwise, you could end up with an unfortunate situation where treatments are targeted at young people who naturally have a greater expectation of remaining years of life, and obviously we don't do that in this country. The other side of the coin on value is how much your product or service costs, and this is something I think people find difficult early in the translation process. So obviously you've got to cost as a minimum what your product costs to make, and also to recoup the investment that you put in to develop the product. You can't charge more really than the value or the benefit to the user or buyer. You need to take into account the budget that the customer is prepared to spend. This is a common mistake where you actually work out the total cost across the patients that it would be indicated for, and it exceeds the budget of the organisation that's in care, so that's obviously going to create a problem. And finally, you also need to take into account any competitors. And as I said, there's often a number of ways of dealing with a need or a problem, one of which might be to do nothing and just accept the consequences. And this slide charts the cost of a treatment against the value generated. And products and services fall into one of 4 main categories. So in the bottom right quadrant, these products add more value than alternatives or existing solutions and cost less. And that's really where you want to be, you know, so you need to think about that in your development process. You don't want to be in the top left because the cost of the solution is higher, but the value is lower than existing solutions, and you're likely to be rejected if you're in that quadrant. In the bottom left, the cost is lower, but the outcomes are worse. Now, this could be acceptable if I give you an example maybe of a treatment for a broken leg, which costs £1 million, but the result is the patient doesn't have a limp, compared with a treatment that costs £100, but the results in a limp, which resolves naturally over a period of weeks. We're likely to go with the cheaper option. And the final quadrant, which is where it gets quite interesting, is where there's a threshold value for cost and benefit, below which a product or service is likely to be accepted. So this is roughly £30,000 per QALY. That's the price that the health technology assessment organisations generally put on the cost of a QALY. So you might be asking yourself, how do I find out information on treatment costs or statistics about healthcare systems and demand on healthcare systems? I've got another talk which I'll be happy, if you invite me back, to go into a bit more detail on these information sources. And they're all free, by the way, which amazes our colleagues in the States, where you have to pay for a lot of this stuff. One thing is that there is a useful guide. Unfortunately, it's not published anymore. I've just shown a screenshot of it. I do have a PDF of it, so it lists common data sources and how you can access them. So I'd be happy to email that out to people if they want a copy of that. My email is at the end of the talk. So if we go on to putting it all together, and I'll come to a couple of case studies, illustrative case studies and strategies to overcome some problems. So the first thing is to kind of review the value propositions that we see and common difficulties. The problem I see is inconsistency between the need, the value, and the evidence. So they just don't match. The technology addresses a need, but the evidence is related to something else. Or an unfortunate case where there is no actual need, or the need is already adequately satisfied. Another problem is that the need is defined too broadly, which makes it difficult to assess the value. So this is maybe where the problem's been defined as diabetes, but actually more precisely, the problem is the need for a more accurate measure than standard practice for diabetes, for example, in a particular patient group. And there's 3 tips that I'd encourage you to do. So firstly, do your market research and talk to a wide variety of stakeholders within the system, not just the professors, but also the people who are doing the job every day, because they might have a different perspective. Ask yourself, so what if I solve this problem? Is anybody really interested? What's the value? And also demonstrate your improvement through getting really good UK-based real-world evidence. And going on to a case study. So this case study shows, I've chosen it really to illustrate 2 problems around a value proposition, and that's related to need and value generation. So here we have a situation where a clinic is sending letters out to invite patients for treatment. A certain number of patients do not attend, and that means that a number of appointments are unfilled. So there's a couple of consequences for that. One is inefficient utilization of resource, and also the do not attend patients could potentially get sick. So here's a potential solution where the clinic sends reminders or a series of reminders to patients via mobile phone texts. That results in, and you'd have to show the evidence to prove this, lower do not attend rates. Lo and behold, the clinic is full. But my question would be, is there really a cost saving, a bankable cost saving due to the filled appointments? We're still paying for the heat, light, and the actual space for the clinic. The wage costs haven't changed. Obviously, we are utilizing the resources more efficiently. So this is one where there's maybe a theoretical cost saving, but are we going to be able to bank it in practice? And also, there is potentially another quick and dirty solution to this, which might adequately meet the need, where the clinic sends letters to invite more patients than the capacity of the clinic. Enough patients turn up, even though some do not attend. Obviously, it's not ideal for the patients in terms of longer wait time, but lo and behold, the clinic is full. There might be some health costs for the patients who do not attend. So that's a downside of that. But in terms of possible solutions to this particular use case or example, so you could restate the value in terms of really bankable savings, such as reduced admin costs or postal charges. You could restate the value in terms of improved patient satisfaction. Obviously, that is important, and wait times will come into that. Or you could restate the value in terms of clinical benefits due to picking up cases that would otherwise be untreated because they did not attend. But you really need to understand the root causes of DNAs, and are they really lost, or will they be picked up at a later stage of the disease through another route? So you'd really have to look at the evidence on that. There is, of course, another solution or potential value at the moment due to the COVID-19 situation, in the sense that you don't want a lot of patients in the waiting room at the same time. So a more efficient appointment system might be the way to go on that. Another example here. So a clinical commissioning group pays a hospital to screen women for cancer. The current care pathway is that the women attend. They take biopsies for some of the women who are invited back, and they are treated, and a proportion will do not attend on the first appointment and also on the second treatment appointment. So wouldn't it be better, and this is an actual technology, where you can detect without a biopsy cancer on the first appointment, and that gives you the opportunity to screen and treat at the first appointment. It eliminates do not attends on the second appointment. And that's really great for the women, and it's great for the clinical commissioning group. And there's a clear cost saving and clinical benefit, but it's really not great for the hospital's finances, because they've been being paid for 2 lots of appointments and they'll just be being paid for 1. So is there a barrier for the hospital to adopt this technology, which is not a clinical or technical aspect, it's just an aspect of the way that the hospital gets paid? So again, this was a real world example. So in this particular situation, the hospital and the clinical commissioning group agreed that this was the right thing to do. They renegotiated the terms of the commission contract to share the benefit so that the hospital wasn't unduly penalised for doing the right thing. The hospital built a business case to repurpose the extra capacity generated to perform other fee-earning activity, and also took the opportunity to reduce waiting time, because we had a demand problem there. More women needed the service than the capacity could allow. And there was also an opportunity to move screening and treatment into a community setting, which was something that the voice of the business wanted to do. So that's kind of a little bit of a whistle-stop tour in terms of the kind of issues. Probably bombarded you with lots of information there. So you might be thinking, help, what can HSNs do for us? So through our Innovation Nexus service, you can actually submit an inquiry to the AHSN and access support such as I've listed here. So business support, mentoring, particularly SMEs within our geographical area, help accessing clinical and academic experts and advice and opinion, training, networking opportunities such as today. Also, we do run a funding scheme annually, funding proof of concept studies and proof of value studies. And ultimately, what we really want to do is assist with adoption at spread and scale across Greater Manchester, to take an idea into something that can help citizens and patients within the NHS within Greater Manchester. So finally, just 3 slides just to kind of summarize in terms of top tips. So first tip is research the market, understand who influences the buying decision, what are their needs and how are they currently fulfilling them? And also, what are the organization's goals and objectives? How do they get paid? Are there any budget silos? The second one is demonstrate your value. If you fulfill the need, so what? What good happens? Is the value realizable? Is it a bankable cost saving? Is it measurable? You're going to be on a bit of a sticky wicket if it is difficult to measure. align with goals and objectives. And also, you know, you need to collect the right evidence. And again, you know, my offer is open to come back and talk through what kind of evidence maybe we could do. It's a bit of an interactive session compared to current practice within the NHS. And the final slide on top tips is engage effectively. One of the most important success factors, I think, is to get a champion within the system, a clinician, a key opinion leader, and to understand the adoption and procurement process, and we can help with that. Health Innovation Manchester. Engage with the right people at the right time, and don't try smoke and mirror proposals, because we've often seen it before, and it can kind of damage your credibility. So that, in 15 or so minutes, is what I'm going to try and what I tried to get through today. That's my email address if there's anything that you want to follow up with later, or you want to access that PDF of the information sources, but I'm open to any questions. Thank you very much.
Thank you, Paul. That was a fantastic talk. I really enjoyed the real world case studies as well. I think there is a few questions in the chat, so I'm gonna just read them out to you, Paul. And so I think Scott Harrison asked, what TRL level are you interested in? And Jonathan has already said TRL4. I don't know if you can expand a little bit more on that. Or... Yeah,
well, ultimately, because our network is care providers, we are really interested in things that you know, are close to adoption. But what I would say is we also have a strand which is called the Research and Innovation Accelerator, which one of my colleagues is going to talk at another session, which is earlier stage. And what I would say is, having seen a lot of things that come to adoption, and you think there are simple things that could have been sorted out earlier in the development process, I'd rather answer questions on something like that and get innovators to create products that are going to work in the system rather than leave it too late. So formally, yeah, we're looking for adoption. That's the nexus of our success, if you want. But I'm always open to talk to people at an earlier stage to put them on the right track with help from clinicians.
That's great. Thank you. So that means that they can submit the innovation earlier on, or just approach you for an advice?
Yeah, they can approach, or they can go through the Innovation Nexus, and we'll route them through to the right people as well.
Great. We got a couple of quick comments from Lloyd, actually. Lloyd Gregory, he's asking, what would you define as real world evidence? And also, is there an optimal time to speak with the expert such as you? So you already answered the second one, but I don't know if you have any comments on what would you define as real world evidence?
Okay, so I can give you an example. A few years ago, there was a big push from the Department of Health around healthcare associated infections. MRSA was really in the news. And it's very, very difficult to prove things like even hand washing works. There's so many factors. So research is very much, you know, a blinded, randomized control trial. And sometimes it's very difficult to prove objectively that something works. In fact, when you go through the scientific literature, there's loads of things that are being used, and you think Cochrane reviews don't really show that it works. So I'll give you an example of that. A company came to us with an alternative to bleach. It wasn't a bleach containing product, it was a quaternary ammonium containing disinfectant, and it had a residual action. So they said to us, we'd like to trial that in a hospital. Difficult thing to do. Bleach is known to work. There's a leap of faith for a hospital to try something new. But we did do, and this is what I would call a real world evaluation, where we cleaned 2 wards with the test detergent over a period of 6 weeks, and 2 with the normal bleach. And then we did a crossover study, and we looked at background microbial counts. So we're not, it was a crossover. There's lots of things going on, but it was the real world. And we did show that the background microbial counts were the same. And that's just about enough maybe to persuade procurement or the infection control people to think, yeah, we should look at this and we should trial it further. So I hope that helps. Real world is real world. And sometimes things go wrong in the real world that don't go wrong in clinical trials and experiments. But you probably need both.
That's great. Thanks, Paul. We got another question. We're running a little bit behind of time, so I don't know if you can answer it with a yes or no.
Okay.
Perhaps we can follow that up later. So Joe is asking if you can comment on what type of innovation do you see coming through Health Innovation Manchester, and what's the time scale for impact? In particular, do you see novel therapeutic agents coming through this route? So perhaps you can answer the last one and then follow that up with Joe separately after the meeting.
What was the example again? The novel?
Do you see any novel therapeutic agents coming through this type of route?
So we concentrate mainly on medical devices and medical technology. So they would be rooted in if it was a pharmaceutical, and it's a different kind of discipline, if you like. Kind of things we see, lots of digital technology, obviously with COVID, telemedicine, teleconsultation. The time scale, it's quite varied. Like I say, if something is in an earlier stage, we will route that through to the right people. So our time scale is pretty quick, to be honest. We're looking for things that can potentially be used tomorrow, and maybe have some are already in the system somewhere, either being evaluated or used, and we're looking to spread and adopt. So timescale maybe a year, 2 years, certainly no more than 5 years, I would think.
Okay, thank you, Paul. Thank you so much. Joe perhaps can follow this up later on
sure.
if you want more detailed answer. But we better move to the second speaker. Actually, is two speakers today. I would like to introduce Charlotte Stockton-Powdrell and Suzzane Carter, who will tell us about the Research Project Managers Network. So this is a network that is really for support to all project managers that are working in health and social care related research, both within the university and the NHS. So Charlotte and Suzzane, welcome, and thank you for coming to present today. The floor is yours.
Thanks, Alessandra, and thanks for having us. Suzzane and I are going to do our first joint presentation here, with Suzzane driving the slides. So please bear with us as we go through this for the first time. I'll introduce myself, then I'll let Suzzane introduce herself, and then we'll start through the slides. So I'm Charlie Stockton-Powdrell. I'm a senior project manager at the University of Manchester, working in the digital health software team. And in my spare time, I am one of the co-chairs of the Research Project Managers Network. Suzzane.
So I'm Suzzane Carter. I'm a project manager at the University of Manchester in Cancer Sciences, and I'm also one of the co-chairs of the Research Project Managers Network.
Great, thanks, Suzzane. Next slide, please. So just a brief outline of the talk today. So we'll talk you through who the RPMN are, a little bit about what we do, the vast amount of expertise we have within the network, and then a little bit about how we can support research. Our remit briefly is that we meet twice a year, where we have a number of invited speakers, and then we provide some bespoke training for our members as part of that process. And Suzzane will tell you a little bit more about the remit within the next few slides, but I'm going to tell you a little bit now about who the RPMN is. So the network was established in 2013 by Cara Avsal, who some of you at Health Innovation Manchester may know, and Alison Littlewood. Both of them were at the time programme managers working on National Institute for Health Research programme grants. And they found that they were meeting and discussing various issues related to managing projects and programmes of work. And they wondered whether there might be other people interested in doing the same thing. So they set up the Research Programme Managers Network, as it was known at the time, and there were probably about 15 or 20 of us at the first meeting back in 2013. Move forward to April 2021, and we have over 200 members now, which is fantastic. So about half of our members are from the University of Manchester, and about half of them are from local NHS hospitals. And as Alessandro said, we support and are a peer support network for people who are working in health and social care research. So we do meet twice a year, and actually our next meeting is tomorrow. And we offer bespoke training to our members because we recognise that the role is relatively unique. And whilst there are some excellent general project management courses out there, it's also useful to have things that are quite bespoke to research project management for our members. And we're very grateful to be supported by the Faculty of Biology, Medicine and Health, and they provide some funding for us to support meetings, to support training, etc. Next slide, please. Thanks, Suzzane. So the Oversight Group, or the co-chairs, are made up of myself and Suzzane, who represent the University of Manchester, and we've recently been joined by Rachel Volland, who works for Aqua, and that is part of Salford Royal, and we're also looking for new members to join us so that we have representation of our members from the university and from the NHS. So I'm going to hand over to Suzzane now, who's going to tell you a little bit more about what we do.
So what does the Research Project Managers Network do? So the purpose is to encourage, facilitate and support effective research management. And we aim to provide a network of support for programme and project managers, share good practice, discuss and evaluate new working procedures, constructively discuss challenges within research management, establish a shared development framework to encourage and support professional development, and provide training and development opportunities for all of our members. So what expertise do we have? So project managers can be brought into a grant at any stage of a project, depending on the need and the funding. So we have a wide range of knowledge, skills and experience across the breadth of the research lifecycle in health and social care. So this could be anything from grant applications through study setup, study management, budgeting and financial management, to closeout and archiving and much more in between. And because we're research specific, we have experience of communicating with a wide range of stakeholders, and that includes funders who've got a variety of differing needs. We deal with commercial and non-commercial research, and also we've got members who deal with all different types of studies. So that could include CTIMs, phase 1, randomised controlled trials, or just basic science studies. So how do we support research? So Charlie's already described some of the things that we do. But basically, rather than providing a consultancy service, what we are is a peer support group of project and programme managers. So we have access to a large number of experienced and well-researched project managers and can help research in the following ways. So we host biannual network meetings and ad hoc training sessions for project managers, and that's aimed at increasing knowledge and development. And project managers can sign up to the network, and you'll receive notifications about events, training events that we put on, and have access to an experienced group of research project managers who will be accessible via email. We also connect people, so after every meeting we have a dedicated networking lunch so that PMs can meet each other and have further discussions also with the speakers. We highlight services, so relevant research services. They're invited to speak, or you can put yourself forward to speak at one of our meetings, and we'll highlight and promote the service that you provide, so that the research managers can promote this in their wider teams and use these across wider projects. We also encourage the sharing of best practice by holding question and answer sessions after our meeting presentations. And this is to gain, it's a way of gaining more specialised advice, distribute ideas and knowledge. And we also send emails across the network at any time, so that could include surveys for data gathering, questions and advice about research project management. We can also help if you're advertising for roles in research project management. So if you're looking for a research project manager, we can send a link to the application across our network, and that should reach a more targeted audience, hopefully generate more interest. And then finally, the Research Project Manager Network have created their own development framework, and this is to help project managers assess where they are in their career and where they may want to go. And Charlie's going to talk a little bit more about this now.
Thanks, Suzzane. So the development framework took probably 2 or 3 years to put together. And we realised that although there are some existing frameworks out there that can be utilised, they weren't quite specific enough or unique enough for our needs. So a group of us got together and looked at what the skills, knowledge and experience are that are required to be a competent and proficient research project manager. So you can see here we've got 4 areas of focus. So we've got project management, research governance, communications and leadership and management. And the framework is intended to help programme and project managers identify areas for development within their career path. So the set of core categories or topic areas have different levels within each one that help provide a structured means for programme managers or project managers to reflect on their knowledge, skills and experience, and also to identify areas for further development. The framework can be used as a basis for identifying training needs in personal development reviews, and because the framework was designed to encompass the variability within the role of a research programme and project manager, we acknowledge that not all of the sections are going to be applicable or relevant for everybody in each of their roles. So the framework is meant to be used flexibly to reflect the current role, and hopefully that's the way it's being used by a number of our members. So next slide, please, Suzzane. So you can see here, we've just tried to identify some of the different stages that help plan development. So we've got some of the skills that we might expect to see at a foundation level when somebody is fairly new to a project management role. And then as people progress, we expect them to move towards the intermediate and the advanced levels. And these are fairly arbitrary terms that we've taken, but we've tried to look at different ways in which we can help people plan for their development and their progression. Next slide, please. So we've pulled together the development framework skills matrix, and this is a fairly quick way of people being able to see where they currently are and which of those skills they might wish to develop further. And as I say, this can be a really useful tool to help in performance and development reviews, particularly when your line manager is somebody who's not routinely involved in your day-to-day work, as is often the case with our roles. So quite often you may find that a project manager is managed on a day-to-day basis or works very closely with a principal investigator who could be an academic or a clinician or a clinical academic in some cases. But actually they may have an administrative line manager who isn't as close to their day-to-day work. So this is a great way of being able to see very quickly and very clearly where somebody's current skills are and the areas that they'd like to develop. So I'm going to hand you back to Suzzane now to tell you a little bit more about some of the bespoke training that we've offered to our members that will help with their development.
So this slide just lists some of the training that's been delivered by the RPMN. So these are training that could be delivered through the university or through the NHS, or sometimes we bring in experts from outside the organisation where we don't have the courses in-house to do this. So these are just a couple of examples: managing people and managing change, influencing and negotiating, project management, etc. So as Charlie mentioned, we don't necessarily have a course, certain courses that you have to go through to be project managers. So this is just sort of filling a gap of some of those training courses that we don't already have. We try to provide a range of trainings to aid the development of project managers, increase the efficiency of research teams, and hopefully take the burden off some of the PIs and encourage a sense of investment across the workforce. So just in summary, the RPMN is a peer support and development network. We're half university and half NHS, and we work towards recognising success and value in research and aim to build capability through bespoke training and the development framework. So we feel that we've now set up a blueprint which can be replicated for other development and peer support networks, and we're opening ourselves up for future collaborations with groups in the wider Northwest and beyond. And unless Charlie, you have anything else to say about that, we can open up to questions.
No, that's great. Thanks very much, Suzzane.
Thank you both. That was very interesting, and it's great the type of support that you provide to project managers across the university. So let's see if we got any question in the chat. Scott is asking if you do accept also industrial members.
That's a really interesting point, Scott. So we haven't done up until now, although I say that we do have one or two members who don't currently work for the university or for one of the NHS trusts. So that's certainly something we'd be interested in doing, and we could have a conversation about that. So please get in touch and maybe we can talk to you a little bit more about that and how that might be useful for you and for us, because I think there are some joint gains there, absolutely.
Good, thank you, Charlie. I'm sure that's how we'll follow that up. There is not a question at the moment in the chat, but I actually do have a question for you. I'm not sure I missed it, but do you provide any support for people wanting to get some project management qualifications? So, like an external one. Is that something like that? I know you say about peer-to-peer support. Does that involve also preparing people to do something like Prince or Agile or something like that?
We haven't done anything formally like that. So we have in the past probably had a fairly informal mentoring program, if you like, whereby people who are interested in becoming a project manager have gotten in touch and they've either joined the network, or one or two of us have maybe had some informal conversations with people and offered some signposting. I think we have a mix of members that some have a formal project management qualification and some don't. I have my own views on whether or not I think that's appropriate. I think a lot of people in our network are extremely capable of doing their job extremely well without having a formal project management qualification. So I think, it just depends what the job needs, really.
Good. Thank you for that. And a question from Sarah. How do you join the network? It's just about emailing you, I suppose. That's the case. Good.
So yeah, to join the network, you can just send either of us an email and we'll add you to the mailing list.
Great. And then there is another quick question we got on Mino left from Joe. Is that they're asking if you can facilitate short-term swaps and exchange between University of Manchester and NHS position to bridge and learn from each other. It would be powerful win-win for the individuals and the UM and the NHS. Do you do something like that? Or
that's a really, really interesting idea. It's something that we have kind of thought about exploring in the past. And one of the ways that we've thought about exploring that is that a lot of the research project managers are on fixed term contracts because their roles are related to external funding that has a fixed term associated with it. So we have looked at ways that we can try and retain good people and retain those skills and that knowledge and experience, certainly within Greater Manchester. We haven't yet found a way to do that successfully because there are obviously many HR hurdles to go through. But if there is an opportunity to do some kind of exchange program, it's certainly something that we could have a conversation about. I'd be happy to talk to somebody about that without making any promises or guarantees.
Thank you for that. And there is also a mention to a buddy system, perhaps, from Kate. So that's something that you could be exploring. So in the interest of time, I think we should draw this session to a close. Thank you to the speaker, obviously, for coming to talk today and for everybody to take part. I would also like to remind you about next month's seminar. So this will be on the 26th of May at the same time, 1 p.m. We will have Professor Andy Vail talking about the Biostatistics Collaboration Unit and another double act actually from Alison Robinson and Kate from the Research and Innovation at the Manchester University NHS Foundation Trust. The link to register to that event should be coming up as we speak. And that's it from me. So I hope you enjoyed the event today. Thanks again to the speaker. Thank you for taking part, and I'll see you all next month.